House Health Policy will come to order. Would the clerk please take roll?
Chair Rogers.
Here.
Representatives Whitsett. Carter.
Here. I think she just on Zoom. Thank you.
Representatives Hadsma. Neely. Here.
You go back to her.
Yeah. Hadsma.
Here.
Neely. Here. Glanville.
Here.
Kafia. Conlon.
Here.
Farhat.
Here.
Fitzgerald.
Here.
Miller.
Here.
Here.
Okay, it's Mike here.
He sidetracked me.
Rankins.
Here.
Vanderwall.
Present.
Filler.
Yes.
Mueller.
Yes. Here.
Van Workum.
Here.
Roth.
Here.
Schmaltz.
Here.
Thompson.
Here.
Kafia.
Here.
Madam Chair, you have 19 members present. You do have a quorum.
Thank you so much. Today we have a very full agenda. First, we will be voting on Senate Bill 219, which does have an H2 substitute. Then we will take up HB 4608 with a vote to report it to the floor. I will then refer House Bills 4513 and 4514 to the Behavioral Health Subcommittee for review. And we will then proceed to House Bill 4434, introduced by Representative Stone, for testimony. Finally, we will hear from testimony on HB 4200 and Senate Bill 31. First up on our agenda, we will be taking up SB 219. We do have an H2 substitute, which you should have in front of you. The only change in the substitute is to address reporting to the Michigan Care Improvement Registry, known as MICR, to ensure that 20-year-olds receiving immunizations also have those records reported. The change is found on page 13, line 8, where 21 is replaced with 20. Do we have any questions on the sub? Seeing none. Representative Hadsma moves to adopt the H2 sub to SB 219. Madam Clerk, please take the vote.
Chair Rogers.
Yes.
Representatives Whitsett. Carter.
Yes.
Hadsma.
Yes.
Neely.
Yes.
Glanville.
Yes.
Kafia.
Yes.
Conlon.
Yes.
Farhat.
Yeah.
Fitzgerald.
Yes.
Miller.
Yes.
Rankins.
Yes.
Vanderwall.
Yes.
Filler.
Yes.
Mueller.
Yes.
Van Workum.
Yes.
Roth.
Yes.
Schmaltz.
Yes.
Thompson.
Yes.
Madam Chair, you have 18 yeas, 0 nays, and 0 pass. The substitute is adopted.
Motion carries. Did we have cards?
Yes.
Thank you. Supporting the bill, Michigan Manufacturers Association, and supporting the bill, Mackinac Center for Public Policy. And also Department of Health and Human Services. Thank you. Representative Farhat moves to report SB 219 with recommendation as substitute H2. Madam Clerk, please take the vote.
Chair Rogers.
Yes.
Representatives Whitsett. Carter.
Yes.
Hadsma.
Yes.
Neely.
Yes.
Glanville.
Yes.
Kafia.
Yes.
Conlon.
Yes.
Farhat.
Yes.
Fitzgerald.
Yes.
Miller.
Yes.
Rankins.
Yes.
Vanderwall.
Yes.
Filler.
Yes.
Mueller.
Yes.
Van Workum.
Yes.
Roth.
Yes.
Schmaltz.
Yes.
Thompson.
Yes.
Madam Chair, you have 18 yeas, 0 nays, and 0 pass. Senate Bill 219 is reported with recommendation as substitute H2.
Motion carries. Thank you for that unanimous vote. Moving on to HB 4608, which we heard testimony on last week. I would like to read in cards on 4608 here a minute. So Laura is neutral. American Nutrition Association opposes the bill. And that is it. Representative Rankins moves to report HB 4608 with recommendation. Madam Clerk, please take the vote.
Chair Rogers.
Yes.
Representatives Whitsett. Carter.
Yes.
Hadsma.
Yes.
Neely.
Yes.
Glanville.
Yes.
Kafia.
Yes.
Conlon.
Yes.
Farhat.
Yes.
Fitzgerald,
Yes.
Miller,
Yes.
Reingens,
Yes.
Vanderwall,
Yes.
Filler,
Pass.
Mueller,
Pass.
Van Workum,
Pass.
Roth,
Yes.
Schmaltz,
Yes.
Thompson.
Pass.
Madam Chair, you have 13 yeas, 0 nays, 5 pass. House Bill 4608 is reported with recommendation.
Thank you. House Bill 4513 and 4514 were introduced and referred to the Committee on Health Policy. It is my intention to have Chair Braybuck and the Behavioral Health Subcommittee work on these bills. Madam Clerk, please read the provided letter.
The letter dated June 22nd, 2023. Dear Madam Clerk, on May 4th, 2023, House Bills 4513 and 4514 were referred to the House Committee on Health Policy. These bills provide for the licensure of art therapists and the profession of art therapy. I am asking the Subcommittee on Behavioral Health to review and make recommendations to these bills. Prescribing professional standards and credentials for art therapy could protect consumers and make these services more widely available. I am confident that the subcommittee will be successful and productive. Sincerely, Julie M. Rogers, Chair, House Committee on Health Policy.
Thank you. Moving along, we will now hear testimony on HB 4434, introduced by Representative Stone. To testify in support of her bill, we will have Representative Stone, and we will then hear from Eric Roth on behalf of Michigan Pharmacists Association. Welcome to Health Policy Committee.
Thank you very much. Madam Chairperson and members of the Health Policy Committee, thank you for the opportunity to testify on my bill, House Bill 4434, on 90-day refills for maintenance prescriptions. During the COVID-19 pandemic, the Executive Office issued an executive order requiring insurance coverage of 90 days of maintenance prescriptions that just made a lot of sense. It meant fewer trips to the pharmacy. It meant less exposure and less congestion and strain on essential workers. But it also had some other payoffs. It meant fewer trips to the pharmacy for people taking daily prescription medications. It meant greater adherence to medication protocols and preventative health care. Every month, individuals making trips to the pharmacy to refill prescriptions for high blood pressure medications, cholesterol medications, and so many others. And sometimes this may require multiple trips to the pharmacy each month for some households. For a 30-day prescription, you generally have about 3 days to refill your prescription before you run out, and then are missing treatments and forgoing the health benefits. For medications to treat blood pressure medication, it can put patients at greater risk of complications. Hectic schedules with demands can pull people in many directions. It can make getting to a pharmacy a challenge. I know I'm not alone in appreciating that during COVID-19, I shared my appreciation with my primary care physician on how much more convenient it is to have a 90-day prescription. She shared that it was that she was observing greater adherence to treatment protocols from her patients as well. Continuing this practice seemed like a common sense solution, putting this policy into statute to continue this option for patients to continue receiving 90 days worth of medications. It will create better long-term outcomes and a healthier Michigan. I'm fortunate to have insurance that makes refilling medications for 90 days affordable. However, patients can decide for a month-to-month refill depending on their copays. This legislation would give patients greater choice in their health care, and COVID-19 opened our eyes that we can take different approaches to many situations. This is one takeaway that we could use to improve health outcomes. I ask for your support in moving this common sense legislation forward. I'll take any questions.
Do members have questions? Representative Miller. Oh, sorry. I will defer first to Minority Vice Chair Vanderwall, and then we will come back to Miller.
Thank you very much, Madam Chair, and thank you for bringing this legislation forward. Just one question to start off. How do we address somebody that would potentially buy a 90-day supply of medication near the expiration of their plan? And how do we absorb that cost, or is it fair to allow that cost to go to the current provider if somebody's going to depart and not have insurance within that 90-day period?
This is one of the challenges in thinking about, unintended consequences, and I'm willing to work with anyone who has suggestions on the legislation. But when we buy into an insurance coverage, it's for 12 months. So if you are starting your insurance coverage and you're partway through a prescription, someone's insurance coverage covered that first part, and it is extending it for that 12 months. You are getting 12 months worth of coverage.
I understand. I guess what I'm trying to get at is if we're expanding it to 90 days, it was 30 days. I think most of us understand and grasp that knowledge. But let's take it, for example, ours. We know that if we don't return, in the December 31st, we're no longer on the plan that we currently are. And if we fill our prescription the week before 90 days, then we're putting the burden on the health plan, which is going to, I would suspect, increase costs. So I'd like to work with you on some details. I've got some ideas on that. The other question, if I may, Madam Chair, one last question before we move on. Have you been in contact with pharmacies at all with this? What is this going to do to their inventories and their costs of doing business if they have to increase the amount of medications to be able to fill these prescriptions?
I'll let the pharmacist speak specifically to that issue, but they're in support.
Okay, very good. Thank you.
Yes.
Representative Miller.
Thank you so much, Representative, for bringing this forward. So can you talk about what types of maintenance drugs this will cover? Will it be blood pressure, cholesterol, those types of drugs? And will the expenses still be the same for, say, if you have a 30-day prescription of cholesterol medication and now you're going to 90 days, will it be the same price since you're adding
Good
more
question.
pills?
So yeah, probably the most common are like statins and high blood pressure, but also I have hypothyroidism. So taking synthetic thyroid is also a pretty common one. And so to refill 3 times would be three $5 copays. So refilling 3 prescriptions at once would be $15.
I see. Thank you.
Yeah.
Thank you for bringing this forward.
Representative Conlon.
Yes, thank you, Madam Chair, and thank you for your testimony, Rep. Stone. This is my 89-year-old mother lives with us, and I spend so much time with the pharmacist that I'd rather not see her every month. But I just have a question. Maybe it's for the pharmacist. Like when it comes to Medicaid, Medicare, and the donut hole, if this gets affected at all with that prescription drug cost with 90 days.
That's something I'll have the expert speak to. Yeah.
Representative Farhat.
I can wait till the pharmacist if you want.
Okay. Representative Carter.
Thank you, Madam Chair. And I definitely could wait till the experts are addressing this. Thank you for your
Okay.
testimony.
Thank you so much. Let's go ahead and have the. Is it specifically for Rep. Stone? Okay. And Rep. Cuffia is yours for Rep. Stone? Okay. Representative Cuffia and then Van Workum.
Thank you, Madam Chair, and thank you, Rep. Stone, for bringing forward this legislation. I was just curious, and you can tell me whether this is one for the pharmacists, but what does happen if they get a 90-day supply? What happens to leftover medicine? How would they take care of that?
So we definitely want to address waste in the stream, and so I think that's something that we're willing to look at. But largely maintenance drugs are that. It's something that people are on for a lifetime, so it's not like an antibiotic. You're on, you're off. And so generally there's not a whole lot of waste.
Representative Van Workum.
Thank you, Madam Chair. Why do we need this law? If pharmacists support it, why don't they just do it?
Great question. For me, this is about adherence to medical protocols and having healthier outcomes. So the fewer times you have your medication disrupted for access, then the better off you are in adhering to those medical protocols.
Sure, so why do we have to put it in law?
To make sure that it's covered.
What part being covered?
Your insurance coverage.
Okay.
Okay, I think we're going to bring up our pharmacist expert, Eric Roth. Director of Government Affairs with the Michigan Pharmacists Association. If you would like to begin when you are ready, welcome.
Thank you, Madam Chair, members of the Health Policy Committee. It's my pleasure to have the opportunity to testify on House Bill 4434 today, which will require coverage for up to a 90-day supply of any maintenance prescription drugs. Now, in my time as a licensed pharmacist, practicing pharmacist, one of the questions we revisit over and over again is how do we help our patients better take their medication? How do we keep them adherent to these drugs, which are important for maintaining chronic conditions and ultimately improving their health outcomes? One component of that answer, as you would imagine, is to make sure they have those medications on hand. You can't take a drug that you don't have on hand. As asserted by the State of New York Department of Health in a document aimed towards prescribers, encouraging physicians and other prescribers to write for up to a 90-day supply of medication for chronic conditions, the department states, refilling prescriptions can be a major barrier to medication adherence for patients with hypertension, high cholesterol, diabetes, and other chronic conditions. By prescribing 90-day supplies of medication to treat chronic diseases, you can help your patients increase adherence by minimizing multiple pharmacy visits. The document goes on to advise prescribers, and I quote, once you establish the long-term medication is well tolerated, effective, and at the proper dose, write a 90-day prescription whenever possible. Providing 90-day supplies to patients has been proven in numerous studies to have positive effects on medication adherence. In a 2018 study conducted by Prime Therapeutics, a pharmacy solutions organization collectively owned by 19 Blue Cross and Blue Shield plans and also the parent company of Magellan RX, found that adherence was 6 to 10 percentage points higher for patients receiving 90-day supplies compared to those receiving 30-day supplies when examined at the 270-day mark. This actually improved slightly to 7 to 10 percentage points at 540 days, which demonstrates that not only does it improve adherence in the short term, but this effect is likely sustained or more substantial even the further you look out. Anecdotally, it would also stand to reason that the patients who would benefit from this change would be those with challenges that would hamper their ability to reach their pharmacies. This would include individuals with mobility issues, insufficient transportation, or without stable housing. Therefore, the Michigan Pharmacists Association believes House Bill 4434 takes a substantive step in the right direction to improving the equality of health outcomes for patients across our state. Thank you again for this opportunity, and I would be happy to answer your questions at this time.
Thank you so much. I think we're going to go back to Representative Farhat and then Carter.
Thank you, Chair, and thank you, Eric, for that presentation. The definition for maintenance prescription drugs, as laid out in this statute, can you tell me how we got to this specific definition in the code, and why either we feel like that is adequate enough or not adequate enough as a definition?
All right, thank you, Representative. So I did have that language in front of me, and as I understand it, the definition for maintenance drug is actually pulled from the section of the insurance code that was aimed at allowing for synchronization of medications, so medication fills. So for those of you who aren't familiar with medication synchronization, if you're taking multiple medications, the goal of medication synchronization is to have those filled all on the same day. Again, one of those steps to help minimize the multiple trips to the pharmacy. So that's where this definition is pulled. And when the medication synchronization bill was going through, I believe it was at least 6 years ago, I believe, they settled on this definition for chronic medications. So I don't know the full history, but MPA is supportive of the current definition. But we'd also be willing to hear if there were any concerns with the current language that's in the insurance code.
Yeah, no. For me, I guess some of it comes from, if we're looking at adherence, I would like to see those studies if you could provide that to the chair. just on what adherence rates have looked like in states where they've done 90 days versus your 30. I would like to see that. Because I think it's important, right, that people are on top of their medication. I think one of the, obviously, is having it at home and having the medication readily available. But I think part of it also is, your frequent check-ins with your pharmacist, right? How's your medication working out? How, especially if it's a newer medication, things like that. So I think there's an important role for the healthcare ecosystem broadly to just have room for that kind of discourse. And then, moreover, I noticed, this is limited to only medications, not devices. So if I wrote a 30-day supply of, I'll use diabetic strips, this is only for drugs, correct?
Yes, sir, that matches my understanding.
Okay, I just want to make sure that that was the case as well. Okay, thank you, Chair.
Thank you. Representative Carter.
Thank you, Madam Chair. And I'd like to ask a question to both. Okay, I was reading the sheet, and I really want to know whether or not, particularly the Repstone, have you had feedback from the health plans and other organizations? How are the stakeholders responding to this, particularly since many of them, and I can attest to this because I'm one of those patients that is currently on a very successful 90-day plan. So how does this reduce waste and redundancy by implementing this legislation? Thank you.
So any concerns that have been brought to us, we're willing to work on.
Thank you, Madam Chair. I would love to work with you on this to ensure that we're not being redundant and wasteful. Thank you.
Representative Vanderwall, and then Thompson.
Thank you, Madam Chair, and thank you for being here. Again, I'm going to go back to the question I asked or somebody else had asked previously. What is this going to do to burden a small independent pharmacy that doesn't normally carry some of these long-term medications in a 90-day supply if they don't have them? Is this going to cause a financial burden to them, or can they still say, no, you can only get 30 days even though it's written for 90?
Thank you, Representative. And the answer to that question is going to vary on which location you're dealing with. I can tell you from my experience that the inventory management systems for these pharmacies have grown quite sophisticated. We advocate continually as the association for patients to really pick one pharmacy and treat it like they treat their prescriber and other healthcare providers, and go to that pharmacy. When you have a patient that is continually filling a maintenance medication with you, that then allows you to adjust and manage your inventory so that you're having enough of the right medication at the right time. So ultimately, while there is a concern with keeping too much of expensive medications on hand, the vast majority of these chronic medications are relatively inexpensive, and the larger metric is actually the turnover rate for the medications. And if you have patients consistently coming in and getting 90-day supplies of their medications, you're still going to have that turnover rate. So will there be a higher cost of goods on hand? Yes, but I don't believe that would be overly burdensome for the pharmacy.
All right, I appreciate that. And one more, if I may, Madam Chair, is, and it was asked earlier, when it comes to supply and then all of a sudden people have more medication left, are our pharmacies willing to take or institute a take-back program so that somebody can dispose of that drug?
Great question, Representative. So many pharmacies already do hold take-back programs for extra prescription medications, and that's something that we as providers advocate. Don't keep extra medications in your house for various reasons. However, with the way that these medications work, usually these maintenance medications are usually products that the patient is on for a long time. it is best practices to only initiate this once the patient is at a stable dose. So ideally, the patient wouldn't actually be ending up with a lot of waste because they'll be taking their medication. If the patient is not taking the medication, regardless of whether it's 30-day supply or a 90-day supply, having a conversation with that patient, between the patient and the pharmacist is going to be important, because then the patient isn't taking the medication that's supposed to be managing their conditions. Their condition will likely worsen. So that's one of the services that pharmacies provide. So again, if I guess to go back to answer your question in short, yes, pharmacies do operate medication take-back programs, but I think the situation is a little more complex than that, and it's something that a pharmacy and a pharmacist would want to have a conversation with the patient if there was, for some reason, a lot of waste when it comes to these maintenance medications.
Thank you. Representative Thompson and then Roth.
Hello, thank you very much for your testimony. My question is, have we talked to physicians? Where are the physicians at on this? And then I'll give a follow-up to that.
Thank you, Representative. I have not spoken personally with the physician groups. However, there's nothing in the bill that would require a physician to write for a 90-day supply. If they did not feel it was appropriate, they could always write for a shorter day supply, and then that would restrict what the pharmacy could then dispense. So I do not see why a prescriber would be opposed to this.
Well, I'm glad that you actually said that. So working with physicians and primary care physicians as a nurse, I think I'm actually the only nurse on health policy. A lot of doctors feel very uncomfortable writing for 90 days because they're not monitoring. And I understand these are medications that patients have been on for a long time, and you want to get a stable dose and you feel safe with that stable dose. But working in healthcare, I know that could change weekly. That could change with something else that they were taking. So physicians, I just want the general public and everyone in this room to know that even though this is a bill that will extend to a 90-day, that is great, because I understand the frustration with going to the pharmacy. But when you look at it from a healthcare provider aspect, not all physicians are going to write 90-day scripts. They're just not going to. They're not going to feel comfortable with it. So I don't want our constituents believing that this is going to be the fix. So we definitely need to be talking with our physicians and see where they're at on this, because it's kind of their call, I feel, if they're going to write it or not. So thank you very much for answering that.
Representative Roth.
Thank you, Madam Chair. Thank you all. Representative Stone. Copays. Is there any consideration for what the copay is? It one copay? Is it 3 months copay? How is that going to be handled?
Thank you for your question, Representative. So I don't want to speak for my health plan colleagues here, but I can tell you that the structures for cost sharing across various plans is quite varied, let's put it that way. So I can't provide a 100% absolute answer. One mechanism is it is common to have equivalent cost sharing for 90-day versus 30-day supplies. And, I also want to be clear that many health plans already do offer this benefit, but the bill does not necessarily address what the cost sharing is going to look like. So I can't provide you with a definitive answer. It's really going to depend on the plan.
Thank you.
Representative Conlon and then Van Workum.
Thank you, Madam Chair. Just to clarify, if it was a Schedule 5 drug, so something that only can be a 30-day prescription anyway, it wouldn't go to 90 days. Is that correct?
Yes, I was just looking. I believe this excludes controlled substances in the definition of a maintenance medication. So Schedule 5 or any other schedule wouldn't apply.
And also, it says here that some insurance companies will not pay for 90 days at a time. Do we have any idea of how many, what percentage of insurance companies? Is that a big group of insurance companies that will not do it under any circumstance?
I apologize, Representative. I don't have a number to quantify that.
And it sounds like the whole donut hole Medicare thing with, I know with my mother, we always worry when we're approaching that cost. And that wouldn't necessarily be changed at all by this. It would just be as it is now, it sounds like, when it comes to payment.
Yes, and again, it's really going to depend specifically on the cost sharing of any plan, when you're reaching deductibles, et cetera. The other thing I'd like to point out is that this wouldn't necessarily force a patient to have a 90-day supply if they didn't want to either, in the same mechanism that it doesn't require prescribers to write for it. If the patient wants a lower day supply, as long as it's within the health benefit that they're prescribed to, they can still get a 30 if that's their preference.
Thank you.
Representative Van Workum.
Thank you, Madam Chair. My question was very similar to Representative Conlon's. Do you have any examples of an insurer that does not offer this 90-day benefit?
Thank you, Representative. And I do not know specifically the structure for any specific health insurer. I can tell you that I personally have had insurance before that wouldn't cover a 90, and that's purely anecdotal. I apologize, but it's that information isn't necessarily widely available. But it is. Even the health payers have recognized that there is a benefit towards adherence, which again ultimately helps a patient stay out of the hospital, helps them live healthier lives.
I'm just gonna interject here just a second. I think we have several members that would like that information. So if Representative Stone could find out at least some examples and direct it to the chair, and then I can get that out to our members. Thank you so much. Representative Carter.
Madam Chair, I'd be willing to work with you from an insurance perspective to help.
Wonderful. Thank you very much. So I'm going to go to Representative Glanville next because she hasn't spoken, Representative Schmaltz, and then we'll circle back to Farhat. Representative Glanville.
Thank you, Madam Chair, and thank you for being here. I think I just heard you answer my question, but I just wanted to clarify one more time because I've heard a couple people talking about the idea of having patients check in with their doctor within that 90-day period and things. So just to clarify, this is not forcing a prescription to be a 90-day prescription. Is that correct?
Yes, that is correct.
All right. So what we're asking here is that if it is a 90-day prescription, it is covered.
Yes, that is correct.
Okay. Thank you.
Thank you. Representative Schmaltz.
Thank you, Madam Chair, and thank you for being here. So if somebody comes in and they want a 90-day supply, and there is a supply there, does the pharmacy have to give them 90 days? Are they required?
Representative, I don't believe that there's anything in this this language that would require a pharmacy to furnish a 90-day prescription. I hesitate because I'm trying to think of a situation in which a pharmacy intentionally would not do it if the patient requested it and if it made sense for that individual patient's circumstances. If for some reason a pharmacy was hesitant to supply the full 90 days, I imagine that would necessitate an individual conversation with the patient where they would have to justify their rationale.
Okay, so it doesn't require a pharmacy to give 90 days?
Not in this language, no.
Thank you. Representative Farhat, and then we're going to read in cards.
Thank you, Madam Chair, and thank you both for the questioning so far. Eric, can you speak to, and this is an important one for me, the reimbursement rate for a pharmacy between a 30-day and a 90-day supply? Is there a drastic difference there if I am a pharmacy filling one type of script over the other? And how does that impact my ability to be a service provider in an area?
Thank you, Representative, and I can speak to it to an extent. The truth is that the reimbursement picture for pharmaceuticals is unnecessarily complex, and again, like cost sharing, it varies depending on which payer you're working with here. One thing that I can tell you is that very commonly there is what's called a cost to dispense that is factored into the reimbursement. If you are dispensing a 30-day supply, a 90-day supply, or anything in between, generally speaking, the cost to dispense and the associated dispensing fee would remain static. So I cannot say with absolute certainty because, again, it varies across the board, but I can say that if a pharmacy was dispensing 90 days, they would only be billing once and only collect one dispensing fee.
I mean, yeah, and for me, part of my concern, right, is a couple things. Is what does that do to our local neighborhood pharmacy and that health professional who can offer insight? And another concern, and I would like to work a little bit maybe with a few folks on this, is if it's a first prescription, if this is my first time writing a prescription, and I'm that physician, and I appreciate the representative's comments about physicians wanting to follow best practices, but it happens, and it might happen where a physician writes a 90-day script for a new maintenance med that you're trying for the first time, and turns out that, this I don't like how this medication makes me feel. It happens all the time. Mm-hmm. We're then wasting the other 60 days worth of medication, hypothetically, because the doctor's going to do a change order on that script or revisit the initial dosage that they've something like that, right? And so I would just like to maybe work with you folks proactively on just a strong way to avoid maybe some of that waste, especially because we see prescription drug costs and ingredient prices keep going up. It really is a burden on the entire healthcare ecosystem.
Thank you, Representative. And if I could just provide a follow-up to that, it's definitely, I would characterize not best practice for when a patient is on a new start therapy to issue 90 days at once. So really this comes down to prescribing best practices, but I do agree with you. I think that, circulation of best practices at any time is a good idea, and we would love to work with you on that.
Thank you. Thank you, Chair.
Thank you. Reading in cards, supporting the bill, Michigan Nurses Association, supporting the bill, Michigan Retailers Association, supporting the bill, DIFS, Department of Insurance and Financial Services, opposing the bill as written, Blue Cross Blue Shield, opposing the bill, Economic Alliance for Michigan, opposing the bill as written, and willing to work with the sponsor, Michigan Association of Health Plans. Finally, on the agenda, thank you for your patience. We have House Bill 4200 and Senate Bill 31, which require testing for lead poisoning of minors. We have an H1 substitute for the bills for Representative Helena Scott and Senator John Cherry, who will be testifying to the substitutes if you would like to make your way up to the table. We will then adopt substitutes and then subsequently hear from individuals, including the perspective of a pediatrician, Dr. Arsala Bhakti, and individuals representing DLEAD, the Detroit Lead Parent Advocacy Group, the Learning Disabilities Association of Michigan, Michigan Environmental Council, Healthy Homes of West Michigan, and the Ecology Center. Welcome, Representative Scott and Senator Cherry. Please begin when you are ready.
Thank you very much, Madam Chair and members of the committee, for bringing me back before the committee on a different bill. These two bills Representative Scott and myself brought forward to the Health Committee last session. There have been a few slight changes, but just to go over it, what the bill would do is we would call it universal testing for lead for infants. So it would require that infants get screened at certain periods, and then they're screened additionally if there are certain risk factors. Just really the genesis for this bill from my personal experience. I live in the city of Flint in Genesee County, and had my daughter in the midst of the water crisis. And when we went to our pediatrician, we were never asked about lead testing. And, being proactive parents, we asked about, well, should we have our child lead tested? And the question back was, well, are you on Medicaid? And we had a further discussion and ended up testing our kid and everything was fine. But that sparked a question in my head about why was that question asked. And as I delved into it, I became aware that in Michigan, all Medicaid children are required to be screened by lead or screened for lead, but that requirement is not extended to the full population. So what this does is it essentially takes those Medicaid requirements and expands that to the full population of children. A couple of pieces I would like to point out. We should understand that whether or not you are on Medicaid doesn't necessarily determine whether you are likely to be exposed to lead, right? There's all sorts of factors, the age of your house, and the environment that your house is in, you know, whether there was previous exposure to heavy industry in the area or what have you. So it can happen to children of all incomes. It can happen to children on Medicaid. It can happen to children who are on commercial insurance. It can happen to uninsured children. So a couple of pieces that I want to point out here is that there is a parental opt-out. So if a parent does not want to test their children, they are not required to under the bill. We also put in the ability for the department to promulgate some rules surrounding about how this works. In the substitute that was adopted in the Senate, all the testing times were aligned with the Medicaid requirements, and we resolved some reporting concerns that pediatricians had, so that was worked out in the substitute. And then finally, there is a ability for the department, if at some point this is not necessary for the public health of the children of the state of Michigan, to alter that testing requirement, and it would be done through the administrative rule process. So it would go through the JCAR process. And with that, I'm going to turn it over to my colleague.
Thank you very much. Good afternoon, Madam Chair and members of the committee. Thank you for the opportunity to testify on my House Bill 4200. So this legislation would ensure that physicians treating a patient who is a minor would do two things. It would test the minor for lead poisoning at the correct intervals and also record the test on the immunization record. The intervals of these lead testing screenings would be determined by the Department of Health and Human Services. Unfortunately, here in Michigan, we are aware of the havoc caused by lead exposure. Lead, as we know, is a dangerous toxin that is particularly dangerous for young children, especially for children 6 years and under, because of their small size and their rapid growth and also their brain development. Lead poisoning can cause behavioral and learning difficulties, anemia, seizures, and other medical problems. It also affects a child's central nervous system if they have lead within their body. A lead test is the only way to confirm if your child has lead poisoning. Let me reiterate that. So lead testing is the only way to confirm that a child has lead poisoning. So it only makes sense that there should be more safeguards in place to ensure kids being tested regularly. Plus, having better records of these tests will also help us and other state community leaders know what communities may need assistance. So, thank you again for the opportunity to give my testimony. I am open for questions if you have any.
Okay, and like I said, we do have a full agenda of several other people that are going to testify, but I want to pause here and see if we have specific questions for the legislators. We will have some experts in lead testifying and a parent, as well as a pediatrician. And then after we finish up with questions here, we'll adopt the H subs. So questions. Representative Carter? No. Oh. Okay. So we... let's see. Representative Rankins moves to adopt the H1 substitute to HB 4200. Madam Clerk, please take the vote.
Chair Rogers.
Yes.
Representatives Whitsett, Carter,
Yes.
Headsma,
Yes.
Neely. Yes. Glanville.
Yes.
Kafia. Conlon.
Yes.
Farhat.
Yes.
Fitzgerald.
Yes.
Miller.
Yes.
Rankins.
Yes.
Vanderwall.
Yes.
Filler.
Yes.
Mueller.
Yes.
Van Werkum.
Yes.
Roth.
Yes.
Schmaltz. Yes. Thompson. Yes. Madam Chair, you have 17 yeas, 0 nays, and 0 pass. Substitute H1 to House Bill 4200 as adopted.
Representative Carter moves to adopt the H1 sub to SB 31. Madam Clerk, please take the vote.
Chair Rogers.
Yes.
Representatives Whitsett, Carter,
Yes.
Headsma,
Yes.
Neely,
Yes.
Glanville,
Yes.
Kafia, Conlon,
Yes.
Farhat,
Yes.
Fitzgerald,
Yes.
Miller.
Yes.
Reingens.
Yes.
Vanderwall,
Yes.
Filler,
Yes.
Mueller,
Yes.
Van Workum,
Yes.
Roth,
Yes.
Schmaltz,
Yes.
Thompson.
Yes.
Madam Chair, you have 17 yeas, 0 nays, and 0 pass. Substitute H1 to Senate Bill 31 is adopted.
Motion carries. Joining us via Zoom and to speak about the importance of early detection and treatment, we have pediatrician Dr. Ursula Bakhtiar. Hopefully I got your name close to correct, but correct me if I was not quite accurate. Welcome.
Thank you so much. It was very correct. Thank you to Chair Rogers and committee members for letting me testify today in support of the House Bill 4200 and Senate Bill 31. My name is Dr. Bakhtiar, and I'm a pediatrician practicing at Corewell Health East at the Dearborn campus. I'm very excited to be here today to speak on an extremely critical issue that you have been discussing, which is very near and dear to my heart as well as a pediatrician: the importance of screening children for lead poisoning. The dangers of lead poisoning are not unknown to us Michiganders, as we all watched in horror the Flint crisis unfold. The impacts of lead poisoning on our youth did not start or end with that Flint crisis. We historically know how this environmental toxin can be a threat to young children's mental and physical well-being. Every day, children across the state are impacted by lead in paint, soil, air, or water. And most of all, it's an invisible threat. It has no taste or physical appearance, so allowing the exposure to happen and go unknown for prolonged periods of time. We are fully aware of the risks of lead paint in homes built before 1978. I myself see tons of patients that are living in homes built before 1978. Many times children and adults both encounter lead from dust particles from the lead paints that falls into the windowsills or floor or outdoor soil. Some of the plastics that contain lead are used to make these toys. And we all know that the child takes their hands in their mouth and takes all the sand and soil and environment, takes into their mouth. Every day, people in our state unknowingly are exposed to lead. And shorter, higher exposures are not as dangerous as prolonged, sustained, low exposures. And that's what we fear. As my respected fellow said, that the impacts of exposure are very long lasting and they're irreversible, and they can adversely harm a child's health. It can affect the central nervous system of the child because the child's brain is very absorbent of lead, and children who are belonging to lower socioeconomic status and are anemic or have nutrition deficiencies, low calcium, are absorbing more of this lead than others. However, everyone can absorb it as in their childhood more than adults. About 40 to 60% of the lead in the environment is absorbed by children. It affects your central nervous system, hepatic system, renal system, which is kidney and liver, resulting in multi-organ damage. It impairs the growth and development, and it leads to serious cognitive disability and behavior problems. Has long-lasting, irreversible effects on children, causing lower IQ, shorter attention span. I have seen increasing numbers of attention deficit disorders. Some of them might be contributing to these increased lead levels. Increased antisocial behaviors, reduced educational attainment, all of which impacts the entire child's trajectory in life. I vividly remember a case from my residency that I had a 5-year-old child who was admitted with abdominal pain, nausea, and vomiting. It was noted in the history that she has been admitted recurrently for about a year with similar complaints, had an extensive workup. At one point in time, one of the surgeons thought that it was appendix and took the appendix out. On thorough history, on their last admission, we decided to ask about lead exposure, and we found out that the father worked as a pottery worker and would come home after working with pottery paints and hug the children every single day without changing or washing their clothes. I still remember she had yellow eyes from jaundice, blue nails from lead deposition. Her levels were in 200s. We had to do chelation therapy on her. She left without any physical complications, but she had severe cognitive impairment. We may be asking ourselves, what can we do to address this? House Bill 4200 and Senate Bill 31 would allow us to better testing and screening for lead. While the effects of lead poisoning are not reversible, we can prevent further exposure by finding it early and then monitoring them and doing removing the sources of poisoning to avoid further exposure. For example, if these bills go into effect And I was able to screen a child at 9 months or 12 months, identify that the risk is existing, and then I can remove that exposure, talk to the parent, work with the state, and then can prevent the lifelong impact that it can have on the child. And this little early intervention would go a long way, as opposed to the poisoning that is going undiagnosed and untreated for 10 years or more. Early detection and screening can make a considerable difference in children all across Michigan. Having seen the impact of lead poisoning in my practice, I hope you can join me and support the Bill 4700 and Senate Bill 31. Together with this intervention of primary prevention, we can help to raise the next generation as bright and healthy youth rather than youth with cognitive impairment. Thank you again to the committee, Chair Rogers, as well as Representative Scott and Senator Cherry for your attention to this matter. I'm happy to answer any questions here today medically, or continue a dialogue with you or your staff after the meeting. Thank you.
Thank you so much for joining us. I know you're very busy in your practice, so we really appreciate your testimony. Do members have questions? I see Representative Fitzgerald's hand up first.
Thank you so much for being here today, Doctor, and thank you for your testimony. My question there is really at that intersection of early intervention and the exposure rate. And you talked about the long-term low dose or low exposure, I guess, has that really lasting harmful effect. So at these points that we're testing the children, is that, I guess, is that early enough, or is the time period between those testing dates enough to intervene effectively based on your medical opinion or based on your experience in the medical field?
Absolutely. So if you test the children early intervention can be instituted. Regularly speaking, I recommend testing at 12 years and 2 years. At that time, if there is any exposure with toys or paint, we can identify it and remove it. So as they are growing up, and we can do early intervention for their cognitive impairment if it has to happen early on. Otherwise, I'm not very clear on the bill, but the bill also says any child under 18 who has higher risk factors. So it's never too late to identify it, but definitely it's irreversible. So earlier you find it, you can prevent that cognitive impairment that is irreversible if you identify the risk. If you believe me, and we started doing this in our practice for Medicaid children, I'd say about 10% children were above the risk level, and I had the state intervene and identify exposures and remove them. And we did not see any cognitive impairment in these children. So it is early enough to do it at 9 to 12 months and 2 years.
Doctor, just a point of clarification. Can you say again the time frame? I think I heard you say 12 years. Did you mean 12 months?
No, 12 months to 2 years.
Thank you. Brett Fitzgerald, are you good? Okay. Other questions? Bless you. I will just say I don't know if you realize, but I'm also a practicing physical therapist, and I've seen some of these in my own patients. So thank you for sharing that really heartbreaking story about the presumed appendicitis and that appendectomy. That is really sad. I really appreciate your testimony, and we will move forward to our next speaker. We will now have Azelda Esquivel, who is joining us via Zoom, and will be speaking on behalf of the Detroit Lead Parent Advocacy Group regarding the importance of lead health screenings. Welcome.
Hi, thank you. Thank you, House Committee, for allowing me to speak. So I wanted to introduce myself and then address the issue around universal testing and why we think it's important. I work with parents that we advocate on lead. These are all parents, grandparents, and just advocates, but more so that have children with elevated blood lead levels. And listening to their stories day to day, there's a real issue out there, and we really need to see this passed. There is a family that had private insurance, was not on Medicaid, and the grandmother noticed that the child was losing their hair, as well as the discoloration, as the pediatrician said, in their feet, in their hands. And so right away took them in, had testing done, and then also had the child tested for lead and found out that they had extreme elevated blood lead levels, especially living in a home pre-1978, unaware of it. It was not something that they commonly heard of. And right there, because they had private insurance, it never it never occurred to the pediatrician that it could be lead or that they should get the child tested. So it wasn't until they seen signs of this child, physically things were occurring. Now this child has had to go through chelation. They have now, I believe they're in second grade, so 7 years old now. But they still have issues in school where they need extra special needs, where they need extra help. They get frustrated because the child can't keep up with the other children. And it's kind of like, well, what did I do? Well, you did nothing. This is where we need to help these children, because it's only going to lead to more services they're going to need. We know for children that go into the juvenile system because they just can't comprehend as other children. So again, we know it's 100% preventable. This is where we want to start at the beginning, as they're 9 to 12 months, and then get them tested again at 2, and just keep checking to make sure that those levels are staying down in a safe zone for them. We know that it is in our environment, so that just goes along with making sure that they're eating properly, making sure that we teach families. That's another program that I lead here at the Center for Urban Studies at Wayne State, is we're working with families and teaching them how to clean their home, get that lead dust out, because we know that young children crawl on the floor, look out the window. So we want to make sure that we're focusing on that lead dust, cleaning it up, because that is 100% preventable and assisting in keeping those levels down. So I want to thank you for your time and allowing me to speak.
Thank you so much. If you want to stay on a second, we'll see if there's any questions from committee members. Okay, seeing none, we really appreciate your testimony. Representing the Learning Disabilities Association of Michigan, we have Amy Bardo joining us via Zoom. Amy, begin when you are ready.
Good morning. Thank you, Chair Rogers and members of the Health Policy Committee, for this opportunity to share our support of Senate Bill 31 and House Bill 4200. The Learning Disabilities Association of Michigan is a statewide nonprofit organization, a chapter of a national organization, and we represent individuals with specific learning disabilities and attention issues, and the families and professionals who support them. We provide education and support to these families of children with learning disabilities and adults with learning disabilities. Now, the incidence of these types of disabilities are rising every year at an alarming pace. Approximately 17% of the children in the United States have a form of a developmental disability, and the CDC now estimates that 1 in 44 children in the United States have an autism spectrum disorder. The National Academy of Sciences Committee on Developmental Toxicology estimates that at least 28% of developmental defects are caused in whole or in part by environmental exposures to toxic chemicals. And when it comes to chemicals, we know that lead has the strongest link, one of the strongest links to neurological harm. In fact, everyone agrees really that there is no safe level of lead exposure for children. The exposure to lead can cause neurological damage and leading to learning disabilities, lowered IQs, and behavioral problems. And recent studies are showing that learning and behavior deficits occur in children even at very low levels of lead exposure, and that those deficits persist. In addition to learning disabilities, lead exposure can also cause intellectual impairment, ADHD, and behavior problems. Scientists also link low levels of lead exposure in toddlers to declines in math and reading test scores when the children reach elementary school. This school year, just over 200,000 students received special education services in Michigan, and 25.9% of those children were identified as having a specific learning disability, and then thousands more have attention deficit hyperactivity disorder. Additionally, this data only represents children who have been diagnosed and or are receiving support. Early intervention is vital for children with attention and behavior issues, such as those caused by lead poisoning. Early intervention relies on early identification. The effects of lead poisoning are lifelong and impact a child throughout their school careers, yet school teams cannot test for lead poisoning. They can only observe the behaviors. And this often creates a challenge of working to differentiate between, is the behavior neurological or is it a student choice? Unfortunately, many times it's seen as a student choice. The more we can know about the causes for the child's challenges, the better we can address them in a healthy way and increase the chances for that child's success in school and in life. Universal testing takes some of that guesswork out of interpreting children's behaviors in schools. Universal testing can ensure more appropriate early and long-term intervention for thousands of Michigan's children. Michigan should lead the way to addressing exposures to lead. And these bills are strong steps in that direction. So we really thank you for your consideration of these bills. And we are more than happy to help if we can be of any further assistance. Thank you.
Thank you, Amy. Do members have any questions? Seeing none, I have a question for you, and you may have to get back to us on this. Is there any data? So you talked about several of the learning disabilities. Is there any data that you're familiar with on behavioral issues that are associated with lead? I've always wondered that.
I think at this point, I mean, and I will get back to you, I would have to say as well that I think my perspective is that it is challenging to get some of that behavior because we don't really know which children are exposed to lead, if that makes sense. So I think that we're seeing an increase, we know we are, of behavior issues in school and attention issues. But again, schools can't test for lead. So there are times where it's possible and probable actually that that it has been due to lead exposure, but we're not treating it that way. And so this is creating an issue. But I will look and see because I do feel like our national office has some of that information.
Okay, thank you. And we have another question from Representative Thompson.
Hello, thank you so much for being here and testifying. So I have a question with regards to other chemicals. When you look at things that cause the attention deficit, autism, behavioral problems, have you looked into any numbers on what dyes in our food, such as the red dye or the yellow dye, how that has an effect on children learning and their behaviors and having ADHD, and then also any other chemicals?
Our Healthy Children Project actually addresses and looks at all types of toxins that impact neurodevelopment and brain development. And so that is something that our national office to our coordinator tends to keep a very close eye on it. In Michigan, we do less with that component. We're doing a lot of work actually related to, of course, lead exposure, as well as PFAS and some other toxins that right now are more prevalent in Michigan. But
are you familiar with the WIC program at all?
Yes.
Now, it was my understanding that the WIC program, when women come or families come to get their 3-month refill of their WIC coupons that are added to their bridge card, they're educated on nutrition, and the child is also up to 5 years old tested for their it's their iron levels. Their iron levels are tested. So I was asking in a previous committee session if that was still going on. Do you believe that if the WIC program was testing for iron and educating families that are low income on the importance of diet, that something could be done in correlation with the lead as well? Would that be an avenue that would make sense?
I think that if it's been effective as far as educating related to nutrition, et cetera, that could be one avenue. I would, if I have a moment, I would share too that because we know that students on children, I always say students, right? On Medicaid are already assessed for lead. But one of the things that has been really struck us recently is that a tale of two families in 2 sentences, right? My family, we purchased a house that was older, and our doctor, and my daughter was about 6 months. He immediately said, "You have an older house and a well, we need to test for lead." And so she was tested and she was cleared. He tested her a second time when she was a little bit older and she was clear and we were fine. I have a friend who lives 3 miles away, not in what is considered to be an at-risk neighborhood. Her house was built much later than 1978. Her children are now 7 and 4. Her 4-year-old has speech delays. Her 7-year-old has autism spectrum disorder and potentially dyslexia. She last year discovered that the door sill on her porch, all of the paint is lead-based paint. she went to her doctor and she said, and he has severe asthma as well, her son. And she's like, why were we never tested for this? Why would we not know this? Perhaps, as a parent, all that guilt, perhaps I could have done something about it. And the response was, well, you don't live in that zip code. Like, your zip code's fine. Your house isn't that old. And so it became, really a challenge. So I greatly appreciate the question about making sure that we are connecting with our families on Medicaid and WIC for sure. But that is also one reason why we are so animate about it really needs to be all children. We don't know for sure what houses or industries existed on our property before our houses were built. We don't know what other exposures there have been. As a teacher, my students have often moved multiple times, and they might be living in a current house now, but that does not mean that they always have been. And if they were not assessed, then they could have been exposed, and we don't know. And we're going on the assumption that now they're in a good house or a good neighborhood and they're safe.
Amy, thank you so much for your testimony. We appreciate it. Next up, we will hear from Ellen Vial from the Michigan Environmental Council, who is also joining us via Zoom.
Hi, thank you. I'm here today on behalf of the Michigan Environmental Council and also on behalf of the Michigan Alliance for Lead Safe Homes, which has worked to pass universal lead testing for over the last 10 years. We've been working so hard on this issue because we know how big of an impact these bills could have on children's health. As my colleagues here have mentioned, in Michigan, we only test kids who are on Medicaid. We're only currently testing about 20% of children in the state of Michigan, despite the fact that 70% of our housing stock was built before 1978. We also know that Michigan ranks among the highest states in the country for children with elevated blood levels, which means we're not testing about 80% of our kids right now. Establishing this norm for universal lead testing is the foremost policy intervention we can take in the state of Michigan to protect kids from lead poisoning and make sure we're finding any exposure early, remediating that exposure, and making sure that the child is safe. All of my colleagues have pretty much expressed everything I was going to go over today, so that's all I have. But thank you so much for hearing this bill, and thanks for giving us the time to testify.
Thank you so much. Do members have any questions? Seeing none. Oh, sorry, Representative Rankins has one.
I was just trying to look up the statistic you gave about 83% of kids are not tested for lead. Where is that from?
Oh, good question. So let me see. Should have had
You
this.
can get back to
So
us
we know
too.
that we test about 20%. So we know that we're not testing 80. I know.
This is like through Medicaid required testing or?
Yeah. So
In addition-
right now, only children in Michigan who are tested or the only kids who are required to be tested are on Medicaid. And I think in recent years, especially during the COVID-19 pandemic, as child wellness visits weren't happening as much, a lot of that testing has really fallen off. Almost 50% of kids in Michigan are on Medicaid. I think it's about 48. And we only test 20. So we're missing a lot of those kids on Medicaid anyway. So establishing this as a norm, making sure parents know, making sure physicians, pediatricians know, is a really, really vital intervention to make sure we're getting kids who are falling through the cracks.
Thank you.
Thank you. Thank you for your testimony. Next up, we have Jackie Hernandez joining us on Zoom also to speak in support of the bills on behalf of Healthy Homes of West Michigan. Welcome.
Thank you, committee members. My name is Jackie Hernandez. I work for Healthy Homes Coalition, and my experience is a little different, but very similar to the testimonies you've heard so far. I came to work at Healthy Homes back in 2018, so about 5 years ago now. Prior to that, I am still a mom of 5 amazing young men. My 3 oldest were lead poisoned when they were little. And at that time, they had levels. We were on WIC, so they would get tested at the WIC office. They had levels that would come back at between 9 and 11. I don't remember that. I remember being told that we had to work on lowering the levels, but I do not remember being told why it was important or that there was an urgency to lower those levels. My oldest son was diagnosed after the fact with ADD and had developmental delays when he started school. He struggled in school, to be just very plain. He would go to school and it was almost as if he was not able to retain any of the information or content that he was being taught. And then weeks would go by and it literally would almost be like a light bulb went off in his brain, and it was boom, there was all the information and content that he was being taught, which caused a lot of stress for him and for our family as well, because as he started to grow, he started to wonder why he was so different, why he couldn't learn and retain information, why it was a struggle, why he couldn't focus on things. And it was frustrating as a parent, right? Because I didn't know that this was a result of lead poisoning. This was just, my other kids were fine. He was struggling and trying to figure out the resources and how to best help him. He had that same issue with not retaining information. And then overnight, it would be like it was all there throughout his entire school career. So when I talk about it being an achievement for him to graduate, it was an achievement because he wanted to drop out. He did not want to stay in school. He struggled to the point where he became very introverted, he withdrew from being very social because he struggled so much and he didn't understand why he was struggling. I didn't understand why he was struggling. So you fast forward 2018, I come to work at Healthy Homes and I coordinate the Get the Lead Out program. So I help homeowners apply for lead remediation here in the city of Grand Rapids. And I'm learning all this information about lead. And I remember being floored and literally I stood there when I learned about the side effects of lead poisoning, ADD being one of them. And I remember I wanted to cry because as a parent, it is the worst feeling in the world to know that you unknowingly put your child in danger, right? I could have done something because lead poisoning is preventable. And this is 20 years after the fact, right? I can't go back 20 years. But I remember feeling as if I was the worst parent in the world because I could have done something and I should have done something, but I didn't know what I didn't know and what I didn't understand. And we lived in a house that is very typical that it had siding, had newer windows on the first floor, but had older windows on the second floor. And my kids played outside in the yard and in the dirt. So I'm pretty sure, and we had peeling and chipping paint around the foundation, right? So all these things, the puzzle pieces started falling into place. And I remember that feeling stays with me. It's why it makes me really good at this job and what I do and why I advocate so fiercely for our babies, because our children should not be used as test dummies to see if a home has lead or not. No lead is good lead, meaning zero lead, because even low amounts of exposure over long periods of time, which is more typical than a high exposure in a short period of time, cause damage. And it causes damage that, to questions that have been asked earlier, we don't necessarily correlate immediately with lead because they might not show up for 5, 10, 15 years, right? And that also depends on the lead level poisoning that the child has gotten throughout their life and where they're getting it from and if it's a continuous source, right? And then if it becomes absorbed in the bones, if it gets to that point where it's absorbed by the body's bones, you basically, your body is repoisoning itself over and over and over. And that is scary because we can prevent this 100% by being informed, being made aware, being given access to the resources, but primarily by testing our kids, because some doctors may not be aware of what to ask. Some might just not want to test your child. Parents don't necessarily know that they are their child's advocate to say, hey, I want them tested, regardless of why you want them tested. And making this like our well childs, when you take them to a well child visit, they get their shots. All of this is part of that process. So you can do more and create more impact by testing kids at an earlier age, because the sooner we know, the sooner we can then offer resources and wraparound services to our families and to our kids to help them mitigate and learn how to manage with any of the adverse effects that they may have. Because make no mistake, they will have adverse effects, but no two kids will respond the exact same way. If you remember, I told you I had 3 kids that tested positive for lead with levels between 9 and 11. The only one that ever demonstrated any developmental issues was my oldest son. My other 2 kids, who also had levels that were between 9 and 11, had never had any issues that I was aware of, were perfectly fine. So it was a very big discrepancy between the one that had issues and the ones that didn't. But it goes to show you that 2 kids in the same household exposed to the same levels of lead will not respond the exact same way. And that's an unfortunate, it's a good thing, but it's also unfortunate because we can't create a baseline. You know, when we get chickenpox, everybody gets the spots, you start itching, you know, you have chickenpox. With lead poisoning, we don't get spots to know, oh, that kid has lead poisoning, right? And lead poisoning mimics a lot of other illnesses. So to the earlier testimony from our pediatrician, people look at other things before they ever think to look at lead, right? And if you aren't aware of certain factors, like if you live in, to know to ask if you live in an older home. I know here in Grand Rapids, 85% of our housing stock was built before 1978. And a good portion of that sits in the 49507 zip code, which a few years ago, up to the pandemic, we had the highest count of kids that tested positive for lead poisoning in the entire state, even higher than Flint. And that's scary, right? That's one zip code, one small zip code in our entire state. So being able to test our kids sooner, being able to test them more regularly will help us rally resources around what families need, what individuals need, and most importantly of all, it will help us protect our kids and show them that they may have been lead poisoned, but that is not the end all of their lives. We can help them to live fulfilled adult lives as they get older. And we can help the parents deal with the struggles of what that's going to look like, right? Having been on the other side of that fence myself as that parent who didn't know, I wish I had had the resources I have now back then, but I can't go back in time and change what was done. I can only advocate for future changes starting today going forward. And one of those is to ask that we test our kids early, and that we test all kids, not just kids that not just the required ones on Medicaid and WIC, that we test all babies, because we don't know where they're coming into, where they may be coming to and getting exposed, coming into contact, and getting exposed to lead. It may be from not necessarily their home, but the environments in which they're in or they are visiting. So being able to test early is very important, because the earlier we know, the sooner we can activate resources, the sooner we can start helping our families and our parents learn what to do to prevent any future poisoning from happening. So thank you for your time today. Thank you for considering this bill.
Thank you, Jackie, for putting a human face on this issue, and I appreciate you sharing your story and your family's story. Do we have any questions from members? Seeing none, last up, we have Melissa Cooper Sargent of the Ecology Center joining us on Zoom. Thank you so much, and thank you for your patience.
Thank you so much for being here today and for taking our testimony. And I'm testifying in support of the bill today. And I'm with the Ecology Center. We have been an environmental health organization for over 50 years and working on lead for easily over 10 years. I'd like to address a few of the questions that came up. And we are also representing the GLEN, which is the Great Lakes Lead Elimination Network, that we work with folks within Michigan and then other Great Lakes states on the issue of lead, because it is so widespread. Ms. Hernandez brought up that 80% of the homes in her area are pre-1978, and that's pretty consistent throughout the whole state of Michigan. 70% of the housing stock is pre-1978, so we know that children are living in old homes that are considered at risk due to lead paint. In 2021, there was a nationwide survey that was done, a nationwide assessment of blood lead levels in children, and Michigan ranked third highest with 78% of the children who were tested having lead in their blood. So it is widespread throughout our state. And one of the reasons why we're looking to test the children at the ages that we are is that when children begin to get mobile, when they start crawling, start walking, that is when they are at greater risk because they're moving on the floor, they're putting their hands up on windowsills to pull themselves up, they're putting their hands in all kinds of places and then touching their mouths, and maybe their face is directly on the floor as they're learning to crawl. We've all seen, babies get into some dusty areas, and that's where it is. It's in the dust. As the lead paint just starts to break down, it gets into the household dust, and especially if there is a well-worn area, like the current paint at the top level might not have lead in it, but you go a few layers down, and that's where the old paint is. So door jambs that have a lot of friction, stairs that have a lot of friction, windowsills that are being raised up and down. So these are the areas that are high-risk areas within the home, but then of course it's also in the soil outside the home. And so it was discussed, some of the health effects that we see with children being exposed to lead. And we do know it does harm the brain. Again, Ms. Hernandez said her son was, grateful, and she was grateful that he graduated high school. And that is truly something to be grateful for. We know that a kid who is lead poisoned is 7 times more likely to drop out of high school and 4 times more likely to end up part of the criminal justice system. It does affect problem-solving skills. People who are lead poisoned are more likely to make the same mistakes and not learn from those mistakes. You're more prone to anger, frustration. So we do know that it does affect behavior with children in schools as well, and once they become adults out in the world. There is no safe level of lead exposure. Children, can cause lifelong health effects. Michigan would not be the first state to have universal testing. There are 10, and I believe maybe now even 12 states plus Washington, D.C. that do require universal testing of children, and they have much higher rates of testing. We are 1 in 4, 1 in 5, right around that area of children being tested under the age of 6. States with universal testing have at least 50%, and some states are close to 100%. And Washington, D.C. is also included in that. So Michigan children not on Medicaid also live in homes with lead and can be exposed. So, and that's been talked about at length. So we know that once a child has been identified as lead poisoned, then steps can be taken to prevent further exposure, help eliminate the lead from the body, get them connected with programs, resources that are available to families, and help to eliminate the source of lead exposure. And I think that covers everything that I wanted to say. And so let me know if you have any questions.
Thank you so much. Seeing no questions, we will move forward to reading in the cards. Michigan Association of Health Plans supports SB 31 and HB 4200. Michigan County of Social Services Association supports both bills. Detroit Lead Parent Advocacy Group supports both bills. Healthy Homes of West Michigan supports both bills. Detroit Lead Partnership supports both bills. Learning Disabilities Association of Michigan supports both bills. Rice and Lanzalotti Family Practice DO, Dr. Lanzalotti DO supports both bills. Learning Disabilities of America supports both bills. Michigan Nurses Association supports both bills, and Department of Health and Human Services supports both bills, as well as Michigan League for Public Policy supports both bills. It's our intention to meet next week at a time and date outside of our regularly scheduled committee meeting to vote out SB 31 and HB 4200. Please watch your email inboxes for news on that front in the near future. There being no further business before the committee will stand adjourned.